Hello everyone, welcome back to another I Care for Your Brain with board certified neuropsychologist Dr. Karen Sullivan. That is me. Thank you so much for being here. Tonight we're going to talk about functional neurological disorder, also called FND. This is a diagnosis that I have cared about for as long as I have known about it, because it is so often a place where people fall through the cracks between neurology and psychiatry. But most recently, I have updated my knowledge on it because of a very special woman named Lorraine, who is the guest on my third podcast, I Care for Your Brain podcast, which comes out on April 13th, which also happens to be World FND Day. So we are dedicating this podcast and this lecture tonight to people who are living alongside this very poorly understood but hopeful disorder, because we are actually starting to understand what really is going on behind the scenes, and most importantly, how can we get people the support and the treatment that they really need and deserve. This diagnosis has been around for about 10 years as FND, but if you trace it back, it actually goes back to a very long time ago when we talked about things like hysteria. It then became known as a conversion disorder, a functional disorder, or a somatization disorder. Thank heavens we have actually started to see some progressive humanity and hope brought into this diagnosis. A big part of that was in 2019, so only about 4 years ago, we actually saw the development of the Functional Neurological Society. And with that, we've seen a huge step forward in terms of validating the multiple symptoms that people have using a new diagnostic framework, which moved us from a diagnosis of exclusion to inclusion. So what that means is it used to just be test after test after test. It's not this, it's not this, it's not this. And basically then some feedback, which was either subtly or not so subtly quite invalidating. And really the message was it's something in your head that's making you do this. It's, a psychiatric issue. It's a mental health issue. Now we actually think of it as an inclusion criteria. So what that means is we actually know exactly what it is we're looking for, and people really do have to meet multiple different sets of symptoms to get this diagnosis. And that's a big part of humanizing it, is goes from kind of being in the shadows to being something that neurologists actually have a much better handle on. But the best thing that's probably happened in the last few years is that we've actually moved into evidence-based treatment. So these are multidisciplinary approaches to managing mind, body, and brain. Part of why I am so attracted to neuropsychology and respect it so much is because we are not participating in this false dualism between mind and brain, right? We really interpret brain health conditions within the context of the individual, the person's own psychology. So I think we really offer a very helpful, really an elegant approach to understanding brain health challenges, including FND. So I want to start off with one very clear message about this diagnosis, and that is that this is not faking. This is not knowingly putting on. FND is a set of motor and sensory symptoms, so think about paralysis, seizures, tremor, that are genuinely experienced by the person but are not caused by a structural neurological issue. Okay, it's the second most common reason people see neurologists. I wonder if you know the first. It is headache. It is migraine. FND disproportionately affects women, 3-to-1 ratio. That does even out a little bit as we get older, but mostly it's something that hits women typically in their 30s through their 50s. FND often causes a very high level of physical and mental health disability, actually more in many studies than things like multiple sclerosis or epilepsy. 20 to 30% of people with FND also meet criteria for a neurological diagnosis. And that gets very tricky. So what that means is 1 in 3, 1 in 4 people who have a diagnosed neurological condition like epilepsy, like stroke, like traumatic brain injury, also are at risk for having functional neurological disorder. In a large cohort study of about 1,030 people, They actually tracked these folks over 18 months, and they found that only 4 of them had actually been incorrectly diagnosed with FND. So that's an important point, because so often people are left with this feeling like, no, it feels so real, it is so real. There must be something, and that can be part of the mental health struggle, is this feeling like no one else is taking seriously what you're going through. So I thought that was important to look at some of the data to see, how often are we misclassifying these people? And it turns out not really very much at all. So what causes FND? When I was being trained 10, 15 years ago, the theory was that it was pretty straightforward, and that it was related to repressed trauma that was held in the body that eventually erupted. And now we have a much more comprehensive understanding that it's really multifactorial, and there's many different reasons across time, so across a lifespan, that make us much more prone to it, make it be triggered at a certain place and time in our lives, and then help to sustain it. So the way we talk about these are predisposing, precipitating, and perpetuating factors. And one of the keys to understand is that this is happening outside of the person's conscious awareness. So a predisposing factor, most commonly, is early childhood adverse experiences. So this would be in the continuum of all the different types of abuse that exist and neglect. And very often when we don't have that early, dependable, safe parental figure, we can develop attachment disorders, and that can really make it hard to develop relationship skills with anyone else in the future, including ourselves. And there can often be kind of a split in how we go through life when we have an attachment disorder, where there's not a real ability to feel like we can integrate or bond or connect to other people. People whose parents were very medically ill as children seem to be at higher risk, probably from being exposed to all the things that go along with a secondary, with an illness. Precipitating factors are the thing that happens right before the FND symptoms start. So this is often trauma, psychological trauma, but it can also be physical trauma, things like migraine, infections. I'm certain this is part of long COVID for some people. There's just a feeling of things being out of control, feeling like you were victimized. Even if it was by a virus, it's still experienced by the psyche as being hijacked and not being safe. Perpetuating factors are what keep it going. So part of that is the interface with the medical system, not being believed. Having beliefs that if you use the limb that's in question, that you're going to be doing further damage. So we often see these very protective behaviors where people actually will stop using their entire arm when they have a tremor in it, because the brain is giving the mind signals that there's danger here. This is a trauma. And with no sound, trusted medical advice, what's a very normal behavior is that you're going to try to want to minimize the trauma, minimize the damage. So we often see people actually become quite deconditioned with FND just out of fear, really out of like a fear response, that they just don't know what to do and no one's telling them what it is, so they don't want to make it worse. So people oftentimes kind of can drop out of very important parts of their life. We see people spending a lot more time alone, a lot more time feeling like they can't engage in hobbies, be with friends and family. We also see a lot of fatigue that goes on with FND, which is probably due to multiple things, but if you just kind of imagine being in a state of having symptoms that are very, very real to you, but never having them validated or really respected or diagnosed or given a treatment plan, it's a very hopeless type of a place to live. And so very often we see people just kind of lacking in energy and then very prone to depression or anxiety. So FND requires that we have 2 sets of symptoms, either motor or sensory symptoms, and we then further classify them as negative or positive. So within motor, we've got things like tremor, seizures, shaking, limb weakness. Then within sensory, it's more of like an unusual feeling or a sensation. So we can have things like pins and needles. It feels like our limbs aren't our own. The limbs just feel kind of strange and not familiar. double vision, trouble swallowing, these types of things. The positive symptoms are when we see abnormal movements, so things that are visible, and the negative symptoms is when there's a lack, right? So we see the lack of movement or weakness. In addition to the motor and sensory symptoms, I, as a neuropsychologist, often see the other 4 symptoms quite a bit. So the first one are cognitive complaints, mostly concentration and attention, and memory. Then fatigue, sleep disturbance, and pain. And in fact, when I look at the research, what the research tells me is these 4 symptoms actually cause more disability than the neurological symptoms. So this is a very common thing that I see, and what we ultimately try to help people understand after we arrive at the accurate diagnosis is that the symptoms of FND can present as very internally distracting. We only have but so much bandwidth to go around and engage with the world. And when we are drawn to a part of our body that is having a symptom, it divides our attention, and it's very hard to pay attention to what's happening now. And if you don't pay good enough attention on the front end, you never really make a full memory of it. So when you go to recall it, it feels like you've lost the memory, but the truth is you never really made it in the first place. So talking about FND requires that we then have a understanding of the neurobiology of the stress response. And so for me, I see dissociation and somatization as very important to this conversation. So I want to tell you what I mean by those, and also let you know not everybody shares my view. There are definitely some people out there who feel that FND has nothing at all to do with trauma or traumatic stress. That's not how I think about it. And the way I feel like I've been educated about it is by closely listening to my patients and by doing a lot of reading on it. So for me, at the heart of FND is a bodily manifestation of trauma. And I do see it in that lifespan way. So there's some type of remote, far away, stressful life event, abuse or neglect. And that sets people up to be 8 times more likely to have FND. And then what we see are precipitating factors, those experiences right before it that are kind of the tipping point, kind of the straw that breaks the camel's back. And what can be very confusing is that those breaking points can actually be not as bad as the early things you've lived through. So that can really throw people for a loop. Like, really? Like, I didn't even put that together, because who would have thought this little issue I had with my cousin would have tripped me off? I've lived through way worse, but really there was just something about it that was the person's breaking point. And so part of how those two things are connected is the way the neurobiology of stress is held in our body. And so as we're growing up, our nervous system is very plastic, very subject to influence, very subject to being changed. And over time, it does become a little bit more hardwired. Not totally, but it definitely has its patterns and its pathways. And one of the main things that we're forming as children growing into adults is a part of our central nervous system called the HPA axis. So this is the hypothalamic pituitary adrenal axis. And this system basically regulates our metabolism and our immune function, which is probably why many people who have a history of trauma have autoimmune conditions. So when that is developing within the context of unpredictability, a lack of comfort, a lack of safety, it becomes very, very, very reactive. It can either go hypersensitive, or it can either go very undersensitive. So people can either become very, very kind of fragile, or they can become very numb and detached. And both of those ways of coping bear on FND and how people do over time. We also see that there's genetic and just psychological differences in our ability to perceive, feel, label, and express emotions. This is emotional regulation. So what we see is people with FND really struggle with emotions, feeling them, perceiving them, naming them, and expressing them. And so some researchers really think of FND as being kind of a primitive, iconic language in which different symptoms have different meanings. And this is the whole idea of trauma being held in the body. And some type of re-victimization can even be symbolic or very literal. In adulthood, kind of pushes what we call the allostatic load. How much can someone bear over the breaking point? So this is important to tread lightly, because the truth is some people who with FND who are asked about a history of trauma are very earnest and say, absolutely not. I do not think anything like that happened to me. So I always keep an open mind. I have not necessarily met these people. Once I've worked with someone long and sensitively enough, there's surely risk factors that are identified and then worked on. But it does bring up this idea that the trauma would have to be a conscious memory in order to be recalled, right? And plenty of times people are experiencing neglect and trauma. We're the most sensitive to it the earliest in our life when we're really pre-verbal. So it's kind of hard to use that as an index people self-report, because sometimes people don't actually know what they've lived through and they are just carrying it in the body. So like I said before, this is now a rule-in diagnosis. So there's really 4 things we use to make the diagnosis. The first one is someone has to have one or more of those motor or sensory symptoms. We have to, through very careful analysis and the very best medical workup, determine that those symptoms are not compatible with known and understood neurological or medical conditions. That's very key. The symptoms cannot be explained by something else, and they have to cause clinical distress and dysfunction in everyday life. Okay? So for many people with FND, they have their own stuff that they come to the healthcare system with. But then, which, this is true, sad but true, their interactions with the medical system actually makes it worse. And so we call this iatrogenic illness. So this is basically the feeling, being on the receiving end of some type of disbelief, blame, humiliation. Now this can be explicit. I've heard horror stories, and in fact, Lorraine on my podcast coming out April 13th will tell you the way she was diagnosed with FND, and it is awful. It is pretty much the worst way I think anybody could have found out. But she's not alone. This is part of how this community is treated, and part of what we absolutely can no longer tolerate. It is really not okay. So subtle and non-subtle accusations that what you are experiencing is being intentionally produced in some way. So in fact, when I was being trained, we were told to give the congratulations, I've got good news, there's nothing wrong with you type of feedback. And of course, that's very invalidating. When you are seizing, when you are tremoring, when you are having double vision, you know that there's something wrong. So we actually have protocols now for standards of care in how someone is to be told they have FND. The problem is getting the word out and getting neurologists trained, neuropsychologists trained on how to give this feedback in a sensitive way. So what would be best is if someone was told the name of the diagnosis, because that doesn't happen always, and being told you are being diagnosed with this because you have A, B, and C. This is what your exam showed. We've done all, people typically go through years of testing before they settle on FND. They're ruling this out, MRIs, EEGs, exams, one neurologist, another neurologist. Finally, someone takes that bird's eye view, oftentimes a neuropsychologist, and then walks the patient through what is this 4 to 5 year history that brings us to today. That is the goal of a neuropsychologist, is to partner with you in order to come to the same exact logical conclusion. Because yes, it is our opinion, but it's also based on fact and a observation of changes in medical records that have happened over time. So it's very important how we talk to people about FND. Just a few years ago at the American Academy of Neurology conference, they asked neurologists, do you think you should be a primary part of the treatment team for FND? And the vast majority of them said no. But here's the thing, psychiatrists also don't really fancy themselves as being the people that folks with FND should go to, because medication oftentimes is not the answer. Medication can be helpful if we have also developed anxiety or depression, or if there is traumatic stress reactivity that we can calm down with medication. But really, it's not something that also falls under psychiatry. So this is where it's been called the blind spot. And this is part of why I think it's captured me so much, is because where are these people supposed to go? That is part of why I try to promote neuropsychology on social media. Is a lot of times you guys don't know we're out here. So we want to partner with you to try to figure these things out. So it turns out if you just explain someone their diagnosis in an educational and a compassionate way, imagine that, it turns out that many people, in one study, 27% of people who had FND in the form of seizures totally stopped having symptoms, okay? Another large group, slowly over the next few weeks, once they were able to understand more, they had decreased symptoms. So a huge part of this is just knowledge, right? It's a knowledge gap. And this is why we need brain health doctors to spend more time with people who have brain health conditions. The brain is really different. The brain is not the knee. The brain is not my finger, right? The brain is the organ of the self and requires a more time-consuming, sensitive, and educational approach. So what is the treatment? So we actually have a gold standard now, and it is a combo of physical therapy, or physiotherapy as you might call it, and psychotherapy. So there's a very specific protocol within physical or physio based on the finding that movements in FND are worse when we are paying attention to them. So you might actually, so if someone's having trouble walking, for example, and you put them on the treadmill and you distract them, they're actually much better able to run than they are walk, okay? And rebuilding those pathways where the body is sending signals to the brain, like I'm walking normally, I'm not disabled, I'm not impaired, that's how we change the message to the brain and we get people better. We also make sure that they feel safe, that they're not guarding their limbs. They're not feeling like they're gonna, they're a piece of china that's gonna break. You actually work on making them feel comfortable in their body. So one research study of 60 people with FND who had symptoms for more than 5 years showed that just 1 week of specialized physical therapy, when it was delivered intensively, led to a 27% reduction in symptoms. That is really impressive. So what about psychotherapy? What do we do there? Well, that's where we create a safe space through a bond type of trusted, professional, appropriate attachment in which we identify the predisposing, the precipitating, and those perpetuating factors. Developing insight and empathy into the reasons our brain has decided this is the only way to hold emotion, to hold trauma, to process it, and to express it. We have to learn to get rid of unhelpful avoidance strategies. We have to teach people stress reduction strategies. And it's complex because everyone's different. So there's not really a very standard protocol, not like a manualized treatment for FND that I would use, but I would say it's having a very validating environment, a very safe professional environment in which we can be curious about symptoms and not judgmental about symptoms. So if you think you might have FND, there's a couple things I definitely want you to do. You have to go into an appointment with a very thorough list of symptoms, onset, triggers, what makes it worse. I want you to really focus on the weeks and months before your symptoms began and try to just anything goes, okay? It can have been a bad migraine, a fall, an infection, you had a bad drug side effect, somebody at work crossed a boundary, you heard a song on the radio that somehow brought you back in kind of a fog to a time in your life before. And then I want you to be very, very brave. And I want you to really talk openly about your symptoms. And I'd actually love, if this is true for you, I would love for you to say, I have had negative experiences with doctors like you before, and I'm asking you to please have empathy and try to help me because I really need answers. And I think personally it would help if you said something like, I know a little bit about functional neurological disorder, and if that's what you think this is, I'm open to talking about it, because the truth is, there is still resistance in saying these words. Neurologists don't have the training of a psychologist to be able to, every single time, I'm not saying all neurologists are this way, but they don't have the training And sometimes, different personalities go into different specialties. They're not necessarily as skilled and equipped to have these delicate types of conversations. And oftentimes they're very good-natured, good-hearted people, and they don't want to say something that might be perceived as mean or rude, or, there's still so much stigma about telling someone, oh, it's mental health instead of brain health, when as if they're different. They're actually exactly the same. We just conceptualize them differently. The other thing I want you to do is just learn everything you can. Understand that this is an objective neurological thing. It's not structurally neurological, which I know it's a little bit confusing, but you have to try to reconcile the mind and body divide that, for whatever coping reason, has started in you. And this is where somatic therapies can come in. So we call these bottom-up therapies, and basically they're based on safe touch and really transforming the relationship you might have to your body through very specific practices. So at the very least, trying to tolerate massage, asking someone you trust and love to give you a hand massage, just being able to be less of an island and experience less separation from yourself and your body and yourself and other people, I think is actually really good advice. And it's often best happening within a trusted psychotherapy relationship. The UK is definitely leading the way on humanizing the diagnosis and treatment of FND. So please look into neurosymptoms.org, fndhope.org, and fndaction.org.uk. Interestingly, the guest on our podcast coming out tomorrow, Lorraine, she is from England. So we're going to get a firsthand account from her on her experience of being diagnosed. And I can tell you there's some low points for sure, but she has absolutely found her way, and her ability to articulate this experience from the inside out is invaluable and something that I am so grateful for. It really helped me understand the human experience of living through FND. So please listen to the podcast tomorrow. I think you'll find it to be super interesting, super helpful. Maybe if you have FND or you think you might have it, send it to someone who cares about you. I think they would really appreciate understanding this really kind of mysterious and still not very well understood condition. I would so appreciate if you would like this video, if you would share it, if you would subscribe to our YouTube channel. We are here to educate and empower. Thank you so much for listening. Have a great day. Bye.